So welcome. I've spent the last month interviewing 13 people, both individually and in pairs, to contribute to the content of this webinar. The people we interviewed have decades of experience in both criminal justice and behavioral health, and we could spend the entire 90 minutes we have allotted today just listing their accomplishments, but that would take away from time we have to share their insights. So I'm just going to run through fairly quickly who we talked to and who you will be hearing from throughout the webinar. So we spoke with Tony Tullis and Judge Manley from Santa Clara, from Mac Jenkins of San Diego. From Santa Barbara, we spoke with Dr. Alice Gleghorn, Judge Flores, and Tracy Makuga. And then we spoke with Herbert Hatanaka and Emily Bell from Special Services for Groups, Dr. Tony Hobson from Plumas County, Cynthia Garcia from the Superior Court of Solano, and from the Superior Court of San Joaquin, we spoke with Judge Flavianos, Jenny Rodriguez-Moore, and Nate Summers. As you can see, we were trying to get multiple perspectives from both small and large counties, urban and rural counties, both people from the treatment side and people from the court side, to be able to get a comprehensive view of the content today. We are trying to distill about 12 hours of recorded interviews into 90 minutes of content, and we fell a little bit short. So we will be breaking at about 1:10 or shortly after 1 for a question and answer session, but then we'll be resuming content at 1:30 to get the content that we weren't able to fit within the 90 minutes. And so you can stay on the call until 2 o'clock if you want to watch that live, but that bonus material will also be in the recorded version of the webinar, and so you can get that when Octavio emails it to all registered participants and watch that additional content on your own time if you're unable to stay past the allotted time of 1:30. We also are planning on developing the additional interview content into podcasts and distributing those in the following months. And if you have ideas about who you'd like to hear from more, let us know that when you email or use the chat function so we can know that as we decide which interviews to develop further into podcasts. So I'm Amy Kimple. I conducted these interviews with Arlie Lindberg, my colleague here at the Digital Council, and I'll be moderating the presentation today. So we advertised the learning objectives today earlier, so I won't spend much time, but basically we'll be talking about what county behavioral health is, how it works, and then we'll be talking about strategies for working effectively with county behavioral health and other treatment partners. So why are we focusing on this topic today? I think that's because there's a growing realization that people in the criminal courts have behavioral health needs, and often when they come into the courts are in mental health or other crises. And we are trying to figure out how to effectively respond to that. AB 1810 is part of that response, but effective partnerships with county behavioral health and other treatment providers are needed regardless of whether AB 1810 had been enacted or not. And to sort of highlight this topic, Judge Flavianos will be sharing one clip.
The point that I've developed in my career over a long, long time, only took me 30 years to figure it out, but is the courtroom, really viewing the courtroom as ER triage. In other words, all the people that are appearing in front of us have injuries that have led them to that point. There are traumas, there are injuries, there's all that undealt with stuff that caused them to be in front of us. So if we want to be effective in terms of using probation or community supervision or parole to turn them into law-abiding individuals, we have to be able, when they come into court, we have to be able to screen, assess, refer, and then leverage. So use the leverage of the court to make sure that people are following through. So the numbers are probably too big to do that for all the population, but certainly the ones that are showing, like I adopted the theory I use in DUI court, the ones that are showing you that they're failing over time, that's when you do it. So let people self-correct if they can. If they can't, then you do the screen, assess, refer, and it's worked. We've got violations down about 30% for AB 109 violations filed with the court since we started doing it.
And so here's Tony Tullis with the county behavioral health perspective.
As I would say as a director, that working with custody and the court is now part of our job. It's a population we're going to continue to serve. Hopefully we're going to get more of them in the community and less of them in custody. But it is now part and parcel of the work we do.
So county behavioral health is basically one of the treatment providers who may be providing treatment in your county, along with private insurance, other community providers, and Veterans Affairs. And we're focusing on county behavioral health because the bulk of the justice-involved population is typically served by county behavioral health. And for framework, we spoke with Dr. Hobson, and he explained that in Plumas, county behavioral health and Medi-Cal are the primary insurance for about 1/3 of the population in their county and for much of the justice-involved population. Who does county behavioral health serve, and how does it work? It serves Medi-Cal recipients and the uninsured in a county, and it's the Medi-Cal service provider for both substance and alcohol use and serious mental health issues. And here's Dr. Gleghorn talking about how that plays out in Santa Barbara.
Yeah, so all counties have that manage mental health plans, and that's basically all counties. Our defined target population really is the seriously mentally ill. And with the implementation of the Affordable Care Act, all counties have a relationship with other providers. In our county, it's CenCal, to provide treatment to the mild and moderate mentally ill. And then on the substance abuse side, we have the primary drug Medi-Cal and federal funding to serve people who meet medical necessity for substance abuse treatment.
And so one thing that's important to understand is that not all the services are provided by county behavioral health employees themselves. Much of the work is contracted out, and so you'll be working with contract treatment providers. And as a point of reference, we learned from Tony from Santa Clara, about 70% of the services in Santa Clara are contracted out. And that will vary county by county, but it gives you one example. So one thing we heard over and over again is that courts need to understand what the funding limitations are for county behavioral health and treatment. And this is Dr. Gleghorn explaining that.
How does someone access care? Who's paying for that care? And what rules need to be satisfied in order for that to be supported?
And so we included this slide because sometimes courts or justice partners have frustrations, and when you drill down into those frustrations, really they're based on funding and the regulations related to a particular funding stream. So it's useful to have a basic understanding to be able to understand that why perhaps some particular person can't be served or why a particular service can't be provided by county behavioral health. And so we're going to go through just the very basics of how some of the funding works so that you have that framework. So here are some of the potential funding streams. The predominant funding stream is Medi-Cal, but there's also the Mental Health Services Act, realignment funds, Prop 47 funds, county general funds, and other grants. And here are some of the grant providers that we heard about from our contributors today. And because Medi-Cal is so important to the funding of county behavioral health, we want to spend a little bit of time. And basically, Medicaid traditionally, which is federal funding, traditionally served 3 categories of low-income people. After the passage of the Affordable Care Act, states were allowed to opt into expanded Medicaid coverage to allow low-income adults without children to be served. And California was one of those Medicaid expansion states. And what that means is the number of justice-involved folks who are eligible for Medi-Cal has increased dramatically. Another thing that's useful to note is that in most counties, there's application assistance for Medi-Cal for the jail population, the AB 109 population, and for people who are on probation. And so that's something you should just be aware is probably happening in your county. Again, because Medi-Cal is so important, we wanted to talk about one particular funding restriction that relates to people who are justice involved, and that's the inmate exclusion. Basically, Medi-Cal funds generally cannot be used for the health care for an inmate of a public institution. And the reason for that is that when Medicaid passed, the idea was to incentivize people being treated in community settings, and so they provided financial disincentives for treating people in institutions, be those mental health Department of State hospital type settings and also in custody settings. California suspends Medi-Cal coverage when someone's incarcerated rather than terminating for up to a year, but if people have been in custody longer than a year, it may take some time to get them re-enrolled. This next slide talks about a really dramatic shift within the way Medi-Cal covers drug treatment. And we got Dr. Gleghorn to explain this. It's probably one of the two longest clips that we're using in this webinar because it's a rather complicated concept, but it's one that's really important for people to understand, particularly if you're working with people who have substance use needs, which most people in the court context are. So I'm going to play that, and hopefully she can give you a brief overview of how this dramatic change has happened and how it impacts you.
So with the Affordable Care Act, the state Department of Health Care Services developed a plan with the counties where counties could decide to offer a much broader benefit for those who were covered by Medi-Cal for substance abuse treatment services. So prior to the implementation of the Affordable Care Act, there were basically really only two services covered by Medi-Cal, and that was methadone treatment in narcotic treatment programs and a limited outpatient treatment benefit. So most counties had very little funding beyond what they could get from the federal government, and treatment services were limited to those two areas. So the state worked with the federal government, CMS, to submit a waiver to the state plan amendment that counties could opt into deciding to provide a comprehensive system of services that they called the Organized Delivery System, which unfortunately, when you use the initials, translates to ODS, ODS. So you had the option as a county to decide to say, yes, we want to provide this benefit of more comprehensive services to all our Medi-Cal recipients that meet medical necessity. So as part of that plan, the state defined that all people applying for substance abuse treatment services would be screened with a tool called ASAM, which is a screening tool developed by the American Society of Addiction Medicine. That's the ASAM. And it basically takes into account all the factors that would determine the severity of a substance abuse treatment problem, the different substances that are at issue, and make recommendations on the level of care that this individual, given their life circumstances, should start treatment with. So all counties that opt into ODS do the ASAM screenings to determine where the client should be placed. And then they place the client in those services and need to be able to show that they have an adequate network to place them pretty immediately. The elements of ODS include residential treatment. They include a level of withdrawal services, so some level of detox. They include aftercare. They include intensive outpatient. They include an opt-in for counties to provide medication-assisted treatment, so medicines beyond methadone, which is already provided through the opiate treatment programs, that can also be beneficial. Any FDA medication approved for the treatment of any addiction, so alcohol, opiates are the primary targets there. Anyway, so there's a whole list of new things that can be covered in a way that was never possible before under the drug Medi-Cal benefit. And the expectation is that people will be screened, placed in the appropriate level of care, and then transition to the next appropriate level of care once they've gone through that.
And so basically the highlight is that there's suddenly increased federal funding and county funding for drug treatment and a variety of settings, but the ASAM criteria is going to be the gatekeeper. And we'll talk about the ASAM criteria in a further slide further along. You just heard a little bit about how the substance use side is funded. And there's a big divide in the way mental health and substance use disorder treatment are both funded. One frustration we sometimes hear from court partners and justice partners and also behavioral health partners is how difficult it can be to coordinate and get treatment for people who have both mental health and substance use needs. What's sometimes called we sometimes call people with dual diagnosis or co-occurring disorders. And it can sometimes be confusing why there's this divide in the provision of these two types of services, even when they're housed within the same agency. And so one thing that we've learned is that there are sometimes different training and different credentialing and licensing for people who are providing these services on the mental health and substance use side. And so that's one reason that you're going to have some division between the provision of these services, but there are also some funding-related reasons to explain that divide. And Dr. Gleghorn is going to talk about that challenge a little bit more.
The division between substance abuse and mental health care is a historical funding division that over the past decade has largely been recognized by everyone coming from the federal government, state government, and down and back up the other way to be an artificial divide, that you need to treat people with what they come to the door with. You need to look at all aspects, mental health, substance abuse, and physical health in providing care, because if you neglect one of those, it derails the rest. However, because of the way the funding streams come to us, it continues to encourage that separateness.
So the next thing we want to talk about on this topic of funding is the need for case management and how that can be difficult or challenging in terms of the funding piece. As you're all aware, many individuals who are justice involved have complicated or multiple treatment needs. So you may have someone who's providing the treatment on the substance use, someone who's doing medication management, and someone who is doing mental health treatment. And so it's really useful to have a case management person who is coordinating those needs and also to act as a centralized point of contact for the court. But funding for case management can sometimes be challenging. And so we asked Dr. Hobson to talk a little bit about some of the funding challenges for justice-involved folks and particularly to talk about case management.
Yeah, the funding piece is tricky, and it's going to vary from county to county. So we've had to cobble funds together from various sources, and as I stated earlier, we cannot offset the cost of our time for Medi-Cal billing when someone's incarcerated. Every service that we offer when someone is incarcerated is free. It's just straight out of the funds that we receive from our realignment dollars, whether it be 91 or 2011. You can't provide mental health. You cannot provide services in the jail that are funded through Mental Health Service Act. That's a limitation. The only thing you can do is prepare for the transition from jail to the community. So Mental Health Service Act funds are not available for the most part in the jail. We utilize a mental health block grant that we get from the federal government to pay for some of our staff time in the jail and to help get treatment established and prepare them for the exit from the jail. Then we utilize Mental Health Service Act dollars for the transitional housing and the full service partnership services. Case management is funded the same. So mental health block grant in the jail, when they exit, we utilize a combination of realignment fundings, Mental Health Services Act, and then the services they provide to the individual in the community, we can recruit Medi-Cal insurance dollars to offset our costs there. So it's tricky, and you know, I don't like saying this, but every county is different, unfortunately. You know, the funding streams are different. Some counties get general funds, and the smaller counties, that's not going to happen typically. So it's just really being creative with the finances you have to make it happen.
We talked with Cynthia Garcia about a similar situation in which she had to be flexible in terms of figuring out and creative in terms of how to fund case management. So in Solano, they had worked with Justice Partners and County Behavioral Health Partners to apply for a Department of Justice grant to fund mental health diversion for high utilizers who were charged with low-level offenses, and a big component of that was case management funding. But then right when they were beginning to get that grant money and to start the program, AB 1810 was enacted, and it really changed the landscape for mental health diversion quite dramatically. And so then suddenly there were people who were eligible for AB 1810 mental health diversion who didn't meet the eligibility criteria for the grant-funded case management. And so Cynthia had to be creative in terms of figuring out what was going to fill that gap for case management. But it just was a good example of sort of realizing that things change and you can't anticipate sometimes where there's going to be a new need. Jenny Rodriguez-Moore from San Joaquin talked about how in San Joaquin County they've really come to rely and prefer court-funded case managers so that there is more control and coordination, and that's particularly helpful for data collection purposes. And so because they are having court employees, they've had to use a variety of grant-funded sources. So they use different grants for different collaborative courts. They use Office of Traffic Safety grant for their DUI courts, and then they use a SAMHSA grant for their drug court case management. And so you just can see from these three examples how you have to be really flexible to fund case managers, but that they're very important to this collaboration and partnership, and basically getting the treatment needs of justice-involved folks met. So now that we've talked a little bit about the framework of the funding and the limitations of county behavioral health and how it works, we want to talk a little bit about how someone could access the system and how that works. So we asked Toni Toulis to explain how someone accesses county behavioral health in her county. And basically, the primary access point is a 24-hour call center, but Toni explained that there are many other referral points. So sometimes people are referred by a primary treatment provider, so a doctor. Sometimes people are referred as they're discharged from a hospital setting or a 5150 hold. Sometimes people are referred through mental health urgent care center or through the mobile crisis team. But that justice-involved folks often are coming into the system a little bit differently. Most of them are coming in through custody, and often they're coming through court referrals, primarily through Judge Manley's court. And again, that's going to look different in every county, but that's just one description. So once you access county behavioral health system, the first thing that's going to happen is that you're going to be screened and assessed. And here are just the list of some of the tools that we heard about, the ASAM, which we've mentioned before, but then some other screening tools that assess for different things. And the important thing to understand is that the screener or assessor may be someone different than the case manager, different than the treatment provider, and it's likely not going to be a psychiatrist or a psychologist that courts may be familiar with in the context of competency evaluations. And that's primarily because these are time-efficient tools, sometimes a few minutes, 20 minutes, but it's not a lengthy evaluation as in the competency context. And so now we're going to talk a little bit about one of these tools, and that's the ASAM. So the ASAM stands for the American Society of Addiction Medicine, and it's a multidimensional tool. You can see a graphic where they talk about some of the different dimensions that are assessed in this tool. And one of the reasons we're focusing on this particular tool is because it's the gatekeeper for drug treatment in Medicaid or Medi-Cal expansion counties, which is most counties. And the second is because we heard in many of our interviews that one of the points of tension when you're collaborating between criminal justice and county behavioral health is when the justice partners think someone needs residential treatment because of the intensity of the need, because they think that that person needs that structure, or potentially needs that housing option, and the person isn't screened for residential, but is instead screened and referred to outpatient. And that can be a real tension between the partners. So we wanted to explain a little bit about why that happens and how you can respond to that. So here's Nate Summers, who's an assessor in San Joaquin, talking about that issue.
Thinking about the ASAM criteria, so it was designed initially for insurance companies, right? So an insurance company is not going to pay for full-blown treatment for somebody that's not medically necessary for. Their duty is to try and pay as little as possible but still, reaching the goals. So that's what it was designed for, and that's what it's being used for by behavioral health right now because they're the Medi-Cal gatekeeper. So they can't just send everybody who ever hits a drug court to residential treatment because that just would be a waste of money. So it's used for medical necessity and reimbursement situations, but for us, that exact same formula works for us as well in terms of referring.
And this is what Dr. Gleghorn thought.
A judge might think this person requires X, but that may not be what the medical necessity screen determines. And so that needs to be worked out because no county in its right mind is going to put someone in a service where it's not indicated because they won't be reimbursed for it. An audit finding is going to come back and take the money away, and that's just going to get them into trouble. So we have to go with the medical standard, despite what the wishes of a particular lawyer or judge might be.
And this is how Judge Flavianos explained this tension and how he handled it.
So the biggest problem is trust and power. People want the power to determine the ASAM and have it go the way they think is right. So it's just getting people to be willing to step back and be able to give up a little control and just kind of trust in the system, and then just making sure that the people who are operating it are doing it in good faith. That's all trust, and it all works out over time with people. You could have people out there making calls that just aren't well perceived or trusted by anybody, and that would cause the system to kind of sort of fall apart. So you have to get everybody together and have enough trust to go with that, with the understanding that we can always change it if it's needed. The nice thing about the Medi-Cal rules is they do require reevaluation. Periodically, and even if it weren't in the rules, people's behavior will tell you if reevaluation is needed, so you always have the ability to adjust later on too. So people need to get out of that I know everything and be willing to step back and trust that. So for me, the learning experience was the RANT screening tool on the DUI offenders, and there are some cases where I'm pulling my hair out. I'm saying, this person absolutely has to be high-risk high needs, and the tool is saying high-risk low needs. And I tell myself, okay, trust the tool. I can always adjust up if I have to. So I learned that through those tools. And if the concern is that they're being put in a lower level of treatment than needed, you can always adjust up. I think, going to a higher level of treatment than needed, it's harder to adjust down, and I think you may do more harm than if you go to the lower level and then move up. Yeah, you should always defer to the lower level of treatment where reasonable.
So you just heard Judge Flavianos talk about different levels of care, and this graphic sort of shows some of the different levels of care under the ASAM continuum of care. And not all of these may be available in your county. Some counties have limited options. And it's also important to remember, as Judge Flavianos was explaining, these are not forever placements. People may adjust up or down because recovery is a process, and people may deteriorate or may get better and then need more or less treatment. So Nate Summers is going to talk about how that plays out in his courtroom when he's doing the assessments or county behavioral health is doing the ASAM.
The ASAM criteria has like 9 different levels, including a medical detox, clinicians, psychiatrists, all these different levels, but we only have access to 2. We have 3. We have medication-assisted treatment, we have outpatient, and we have residential. We don't have the luxury of the medical detox and all these other things, so it really isn't, to me, when I look at it, I feel like I'm the ambulance driver, okay? I show up to the scene of the accident. My decision is, do I take them to the hospital or do I take them to a doctor, right? It's really the only choices I have. So it's pretty easy to get that. And even, again, so when the people hold back and aren't being honest, if they're referred to outpatient, we monitor them really closely and we check their adherence to the treatment plan. And if they struggle and they weren't honest about their initial assessment, but then they show this other side and they actually have these other needs, we find that out and then we adjust them to the other side of the program and put them where they need to be.
So as we talked about, the substance use and the mental health side are a bit different. So there's not necessarily a graphic I can get from ASAM that talks about the mental health continuum of care, but the same thing exists where you have levels of care between being treated in the community and then sort of ramping up until it's more and more intensive into an institutional setting. So we asked Tony to describe how that looks and what the levels of care are in Santa Clara, and this is part of her response.
We provide services at every level. We start with, if we want to start on the high pyramid, it would be the most intensive services, which are emergency psychiatric, the emergency psychiatric unit, or inpatient hospitals. And those would be for individuals that have the need to be hospitalized on involuntary holds. The reason I'm saying this is that's one piece of the system, and I think often for outsiders and maybe for judges, there's a, they're in the hospital or they're somewhere in the community, and I want to make some distinctions. So in our county, we have expanded a great deal of crisis services in the community, and we've just released RFPs for intensive outpatient services, the ACT model, assertive community treatment, and actually we're also implementing for the first time ACT and a forensic assertive community treatment. And these are for people who could step out of hospitals or involuntary facilities and receive their care in the community. So those are new for us, very, very high level on the adult side.
Tony also talked to us about other parts of the continuum moving towards what she considered to be one of the lowest levels of care, which were the wellness centers, and then talked about how people could be stepped up or down if they needed more or less treatment, because similar to the drug context, there's very few people who are in a forever placement and aren't going to have variable needs during their treatment. Tony also talked about the importance and how her county behavioral health unit is working on trying to do outreach to engage folks who may be difficult to get into services, particularly folks who are homeless and have co-occurring mental health and substance use disorders. And so I know that that can be a challenge in many counties.